So I'm a strength-based practitioner, and I would say that to be salutogenic, you have to look at more than sort of what we as physicians are asked to do, which is document how well we treat disease and generate those RVUs. So the billers and coders and the administrators that probably think about the same way here as they do at University of New Mexico Hospital feel that, quote, we are worth keeping in the hospital, keeping our family medicine service, all the ways that family medicine unfortunately has to sort of justify its existence. Acknowledging the indigenous, unceded, stolen land on which we reside. And sort of this is a nice picture. I did a little bit of reading myself on just the indigenous history. I believe, correct me if I'm wrong, but I think Madison is on Ho-Chunk territory. Is that right? Yes. Don't worry about the objectives except for the last one. Have some fun learning with our hearts. Why would I show up at 4 p.m. thinking that you're working with a full tank? I wouldn't, because is it everyone in the room residents? Yeah, okay, y'all, especially as the ones who work a lot more than the rest of us. So just a quick intro about myself. Dad of 4 kiddos, youngest of which has joined me here in Madison. My wife is from the Navajo Nation, which sort of led from me being an East Coaster to coming out to New Mexico. I am not Native American, but a lot of my work is focused on improving health for our indigenous communities. These are sort of like the big picture of what I do. I love taking care of patients. I do, find that grounds my work. But for those in the room who have already figured out that I don't think I'd be happy just being at a FQHC, seeing patients 5 days a week, there's a lot of ways that you can, really develop your tools as a healer and still see patients, or maybe not. But some of mine, DEI work, writing for wellness sort of work. Just yesterday at campus, I was bringing a group of people together to do creative writing as sort of an avenue for self-care. And just like we stretch sort of ways to make people smile and loosen up, a lot around movement, lots of privilege, a few that I've named. I think it's important for me as a white heterosexual male to understand that I've gotten to where I am with a lot of doors being opened. And for those who have not ever sat and just written down one by one the realms of privilege, I'm currently fasting for Ramadan, but I think that one at the bottom, assumed to be Christian privilege, sort of asterisk C, white privilege above, I think it gets me in places. So I think it's an important exercise for all of us. So now we're going to talk about kind of a different way of thinking of our patients and our communities' strengths, and just taking this quote, sort of a wake you up sort of quote. John McKnight, along with some colleagues, I believe at University of Michigan, sort of coined the term asset mapping. ABCD, asset-based community development, was their sort of manual about 30 years ago. I always say that asset mapping and strength-based ways of seeing are much more owned by our community elders, indigenous communities, for instance. But does anyone willing to just give me a quick reaction that you have to that quote? What strikes you? What makes you uncomfortable? If I looked at all of our collective personal statements to med school, and then personal statements to get to be an esteemed University of Wisconsin at Madison resident, we probably talk about service. And so what, to me, this is saying is service is not enough. Service, but in a way that is seeing deficits and making people dependent on us because we're only mapping out what their addictions, their diseases, their trauma is not enough. It's masked by service, but it's not. It's actually ultimately the enemy more than poverty, sickness, and disease. Okay, so just a couple questions. Why don't you turn to your neighbor? You can choose one or both of these, and I'm going to get you warmed up. If you're on Zoom, you can turn to your neighbor who's off camera, or you can just think about how you would answer these questions for yourself. I'll give you 60 seconds or so. So pair up with your love stretch partner or whoever is sitting close enough to you, and just share an answer that you have to either of these questions. Go. See if you want a partner? CSN will be really good at this.
Yeah, I love that too.
I heard that.
It's kind of cool.
Yes.
I'm sure.
All right, so that's warm up number 1. Seems pretty random. It probably does seem salutogenic. They're salutogenic questions. Actually, Dr. Rico, one of the first things you taught me, and I love having these moments where I can honor my teachers. One of the first things that he taught me, and I think you were giving a talk on it, was, and I thought about, but it would have started to be a longer list here, was what gives your life purpose at the moment? And you specifically had this JAMA article that basically showed sense of life purpose was as important as CAD in terms of mortality. And so that would be another great, but let's actually kind of show you that these were not just random questions. I want you actually for a moment, like think of you tomorrow in clinic or at the bedside in the hospital or in a community setting that you might be doing work, research, etc. If those were opening questions. If we thought about health and we cared to map out what people are doing well, we would be much better or much better served to ask these questions than, I saw your labs. I see you're here for your knee pain. Where does it hurt? What's wrong? What brought you in today? I.e., what things are going wrong? And everyone understands the unwritten, and what brought you in today is bring out your written list of the 6 things that you have that you're convinced are killing you, and we'll talk about them. I.e., I'm not really interested in what you're grateful for, how your life is flourishing. For instance, to someone who says, and I'm sure all of us in the room would, part of our brain is going to go to, well, I don't have time. I'm completely strapped for time as it is. Primary care isn't given the time to really no RVUs on actually connecting with people or talking about these things. So how could I fit that in? But I would say, for instance, if someone couldn't tell me what they were grateful for, that's an exam finding. That's an important finding, that this person, maybe the biggest thing that I can then do in the next 15 to 20 minutes is to understand myself as a healer, that their number one health issue is the inability to see the sun coming up, to notice the 20,000 breaths. And maybe I can do some work that probably is pushing away from the computer and really trying to make a connection with them. So for instance, I think absolutely and completely relevant to whatever plan for their hypertension is an answer. How is their life flourishing? Well, in the same way you've been able to do this amazing thing by getting your hands into the ground and gardening again, I want you to, that's already part, you're already halfway to us getting your blood pressure under control. But now let's take also some of those same things you just told me about, how you got to that place from being someone who ate really just junky processed foods. And let's think about how we can use that same thing into, maybe taking your medicine more than once a week as one example, but also maybe taking some of those foods you're now growing and incorporating them into our plan. Actually, I want to take you off your medicine and see if we can make your garden your medicine for your hypertension. Lots of ways, again, thinking salutogenic, that you might go with it. I'd also like us just for a second to focus on how, at the end of the day, if I peppered in questions like these, let's be selfish for a second. We probably label a lot of our patients and youth at risk. Well, we are at risk for that horrible thing called burnout. Medicine is not an easy thing. So if I had these questions and these conversations with my patients tomorrow in clinic, how do I think it would change the encounters? How would it change how I felt at the end of a clinic session, or a full clinic day, or a day in the wards, if I was really connecting with people? And while I'm at it, if I'm a senior resident, how about if we started our morning as a team and spent a moment in gratitude, or did a mind, body, spirit, social stretch? Would it enhance our ability? Would it enhance us as healers? And would it enhance the culture? Would it do something positive for us? So warm-up number 2, you can do this written or just thinking out loud. Pick a patient right now that you're currently taking care of, maybe a hospitalized patient, maybe a patient for whom you're the primary care. And I want you to pick someone that you feel like you're really struggling right now to meet their needs. If we weren't family docs, we might label this person a difficult patient, but hopefully we understand that we're just struggling to meet their needs. Our gut does a little bit of rumbling when we see that they're on our schedule, for instance. Pick that person. Nod your head yes if you have that person. Okay. And I think it's actually better to, if you can, to write this down. So now write down in the next, I have a timer here, so I'm going to do good science and give you the same 45 seconds to write down everything you know about what this person has from a health standpoint, which is really to say a deficit standpoint, because that's pretty much the model that I think most of us have been taught and work from. So just think about, what do you know about this person from a deficit lens? Things that are contributing to them not having optimal health, be maybe another way to say it. All right. 45 seconds to write down what you know about the strengths of this person. Could be things like healthy habits, social support, positive health indicators, SDOH. You always think of in the negative, but potentially. Sorry for making you work late in the day. Okay. And then I would like to hear, and people who are joining virtually, you're welcome to chime in as well. And what does that make? What does that exercise make you think about? Any reflections from doing that? I haven't published anything on this yet, but it seems like it's about a 3-to-1 ratio generally. Occasionally, I've had people actually have more strengths, more answers here than they do here, but in general, it's a 3-to-1 deficits to strengths. And even I sometimes will add this further question, which is, in your last visit with this person, if you could just take the tape recording, what amount of time was spent on deficits and what amount of time was spent on strengths? And there it's more like a 6 to 8-to-1 kind of ratio. I need to actually get scientific and make this a study, but meaning, like, even if I know some strengths, we don't actually spend any. I just kind of know. We talked about it 6 years ago when I first met the person, but we don't actually put any airtime to gratitude or where your life is flourishing or your relationship with your four-leggeds or your great neighbor that checks on you. We really focus on your congestive heart failure that continues to be out of control, and that's 98% of our relationship. Anyone want to share? This time I'm not moving on until I hear at least 1 or 2 residents tell me a thought that you have from that simple exercise.
I wish it didn't take so long to think about strength. I wish it was so much easier when I'm focused on that. Eye-opening.
Is this a person you're going to see in the next?
Yeah, I see him like every 4 weeks.
Okay.
Yeah.
What's a specific question or place you want to go with your next visit?
I think we want to explore how you feel overall on what is going well, and if anything would, like, what is one goal that you would have for just his day-to-day living.
Great. Just make it really concrete. Yeah. I think, like, where is it that I have this sort of black hole that I know nothing about this person right now, and just by doing this, you are absolutely you're gonna walk out of the room in 4 weeks time feeling better about what you were able to provide. You're probably going to provide more effective care. Definitely going to develop a connection that's not just, oh, this is a person who takes care of my X, Y, and Z problems, but this is a person who actually cares for me. When I was an elementary school teacher way back when, one of my favorite quotes was, the students don't care to learn until they learn that you care. So I think of how we are taught medicine and how people like me teach medicine in a way that has no importance on developing a trusting relationship. It just is like stamping out, and can I tell my attending, as a resident or a med student, that I addressed all 6 chronic disease things? Most attendings aren't pressing us, and we as residents who are now teaching med students are probably not pressing us. Well, what did you do to make this person feel comfortable in the room? What did you do to elicit what's important to them? And I understand the chart says there's these things going on. I really don't differentiate between someone more acutely ill in the hospital. I still think we can do much better than what we on average do. Thank you for sharing that. Anyone else want to share?
Kind of made me think, my patients, I focus so much, I guess, on the deficits and the negative the only positives I could really come up with were kind of like lack of deficits, not even like true, positives. But then even
Give us an example of a lack of a deficit.
like just that she, like doesn't have diabetes. Like it wasn't that she's like thriving in this area, it's like she doesn't have these things. But even how much she focuses on the negatives of her social situation or her deficits in her health or whatever, that we just have not even like explored positives at all. That just really made me think, like, what am I asking her, and then what is she giving back to me? Because we're both really just focused on the negative aspects of her health that we haven't even explored.
So where do you want to go with your next visit?
Yeah, I think I could do a lot to focus on. For her, there's just a lot of like it's so much social stress and like things in her life, outside of like her true, I guess, like health stuff, but focusing on the positives of what in her life, maybe what she's grateful for, maybe what's been going well, even like those warm-up questions you asked, and opening with that just to set a different tone for the whole appointment, because the whole appointment is usually just focused on negative things.
That's great. And I think in that just some humility that I think I've been part of feeding into, that all we talk about, make sure she hears it, that I'm owning that our conversations have sort of been missing a big part of what's important. And I'm owning that. So I'd like to bring in, I'd like to hear a little bit more about where you think your life is flourishing right now. Again, if it's dead silence, you didn't fail. You just did an important exam. You found the S3 murmur, and you're gonna just with yourself, not your medical training, just being present in the room, making eye contact. You're gonna know what best place to go. I'm not. Don't even need to give you the script, but just when you have this and it feels like it's not working. And you always have to use emotional intelligence. If your patient, either of these two, comes in crisis moment, it might not be the perfect opening line, might not be what you're grateful for, but I would still suggest that that is a pertinent question to get to and somehow to circle. I love how you said just lack of disease X is sometimes the best that we could do to actually strength map a given patient. And it's not either of your fault. It's not any of our fault. It is though a sort of a symptom of a sick care way of doing health, and not, I think, why we're putting all the time and energy and hours that we are into being healers. I don't think it's getting us to be healers. I think we actually unlearn how to be healers. Healers is like what our grandparents know how to do without a medical degree, and we sort of get cultured into this place where you've known these people for a long time and yet can't say really anything about who they are. And again, what we think of as health is really just deficits. Let's just call it that. We're not describing in this HMP anything about their health. We're just deficit mapping. Because I don't even see anymore, and I'm not gonna say anymore. I'm not saying we did it well back in the day, but I don't even see, like, in a social history, I don't even see in admissions to hospitals like any sense that we even sort of had any interest in who this person is or what their situation they're coming from. It just seems like it's actually deemed irrelevant, and clearly it's central. Was there another hand? This can be our last slide. We don't have to do anything more. So
I was just gonna say, I think like I'm honest about it. There's kind of like some fear underneath all this, with like on my side and on the patient side. Like the patient, like we're all kind of scared of getting sick or things getting worse, or at worst case scenario. But I think I'm scared that I'm gonna miss something or not need make the patient bad. Just like piss them off if they're coming into. I think like looking almost for that expectation of like that deficit mapping, and then I start asking them like about how they're flourishing. So I guess you just have to kind of sit with that.
Thank you. Did you have a difficult, a patient that you're struggling to meet their needs that came to mind?
Yeah.
How would you propose to do this with this specific person? You're sitting with it, you're going to sit with it a little bit more, but right now off the top, what do you think you would do with them in your next visit?
That I tried to do in the last visit a little bit, it's like kind of take a step back and take stock of like where we started and kind of where the patient's got to do. Like he has made really great use to his health, and I think that kind of opens up an avenue to talk more about his actual life.
Great. And again, just owning that I don't think I have opened up our space enough to really hearing more about your life. Can we make a little space for that right now? I can trust from just how you're sharing that this person is not going to think that you're ignoring, the actual things that need to happen to address medications and uncontrolled health conditions. You're doing it so that you can more effectively do the addressing, because you have someone that really trusts that their doc knows who they are, knows that they care. I had a patient recently who came home from the hospital with AFib, RVR picture. And I said, man, Johnny, did anyone in the 4 days in the hospital, you're clearly rattled. You're scared that you've been given this sort of terminal diagnosis. Did anyone in the 4 days notice that your A1C went from 9 to 6? No. This was deemed unimportant. So here's this guy making this really big life change, and all that it takes to go from 9 to 6. And I know this, and I know what he's been doing. And in a moment where he's so scared about this diagnosis, that probably to him is like, why now? I'm doing so much for my health. Why would this happen? Yeah, that's going great. Well, no need to. Why would we waste our time or his time mentioning it? And this is a person who's 24 hours a day in your hospital. It's not like you can't even use the 25-minute, 15-minute clinic visit excuse. That's what we spent. We talked about RVR, but we talked about it in the context of the way he had really taken some huge, courageous strides toward his health. An elder you're seeing post-stroke shares they have a 5th grade education, and since you're doing good strength-based work, they also have some space to share that they're a traditional healer. And so I asked the question, how would you document their education level as you chart about them? I'm going to say that 98% of the time it would just be 5th grade education. And I'm going to tell you about a traditional healer in the red bandana who is an example. This gentleman, Bahi Many Beads, married us, my wife, in the middle on our wedding day in northern Arizona near Flagstaff. But Bahi Many Beads was in his 50s before his mentor, Hatakli, as they're called in Navajo, traditional healer, said, you know the songs and ceremonies and prayers enough, you can be on your own. So I since this is sort of my DEI work coming into this, I also think that by not being strength-based, we do a lot of disservice to those who come from marginalized backgrounds of all sorts. And in this case, we're choosing to emphasize something that we know, European formal education, 5th grade level, and we're often uninterested and don't value and don't take time to understand what being a traditional healer is. I would actually say, if you want my best answer in that scenario, I would say the best answer is list both. Because I think 5th grade education, in terms of the materials I'm going to give him, may actually be important. big semicolon, also studied 30+ years to become a traditional healer. And so I do a lot of speaking on decolonizing ourselves, decolonizing our healthcare. And that's where the sort of intersection for me is with strength-based, because if I'm strength-based, I'm not going to miss and dismiss things like traditional healer. I'm going to see it, I'm going to hear it, I'm going to want to know more about it. Even if I have no idea what being a traditional healer is, I'm going to be genuinely curious about what that is and not just scribble down 5th grade education. So Bahi Manybeeds, an amazing person. We lost him early in COVID. And so I think about when he walks into a health clinic, again, under the guise of health, these things might be said and written. And I'm just gonna, since I'm a glasses wearer, take off my deficit lenses. These are good strength-based lenses on, and I'm gonna see with different eyes. The same person. The issue is not the elder or any of our patients. This is just a clear reflection of the person doing that charting and doing that recording. And this is also a clear reflection of the person doing that charting. And I would say that knowing this gentleman, this elder, as sort of a grandfather figure, not, I've never taken care of as a patient, I look at this slide and I say, I don't recognize who this is. And I sure don't want someone who thinks this to be the one treating him. For instance, low English proficiency. No, we're deficient in being able to communicate in Navajo. He's fluent in a language that is disappearing. He was never given the right in the 1920s as a Native person on his own land, but not considered a US citizen, to attend more than, I think in his case, 3rd or 4th grade education. He has a PhD equivalent in Navajo culture. So in a deeper way, I think this is really about seeing people, really trying to see people. And the slippery slope that seeing patients is really just seeing medicalized beings, and seeing people is understanding the context, for instance, in which this gentleman grew up and what he's had to go through, but also that he's in his mid-90s leading all-night ceremonies. Navajo ceremonies aren't like 20-minute doctor visits. Show up at sundown, we're going to sing and pray until the sun rises. And he's in his mid-90s leading it. So I look at many chronic health conditions. Any of us make it into our 80s or 90s, we're going to have a long list. It has nothing to do with salutogenic way of thinking about him. This guy is at such a high level. He passed right before his 95th birthday from COVID, but such a high level of functioning that's much more just actually important for taking care of him. So I'm going to kind of end there. I would say asset mapping, again, is sort of more coined in public health and social work. It really hasn't gained a ton of traction in our darn deficit addicted medical system. But identifying and amplifying strengths, resources, talents, culture, language, etc., to improve health, versus what I think our model that we operate medicine on, that we are told we're worth something or not on RVUs, is deficit mapping, identifying and amplifying deficiencies, diseases, addictions, risk factors, etc. I put, quote, improve health. I don't think fundamentally that you can improve health in that model. So let's see, 450, by not focusing on strengths, again, some of the key, we've touched on, I think, all of these. Sort of ask this question often to myself: if I spend a day in medicine clinically dehumanizing my patients, how am I able to say at the end of that day that I still retain 100% of my humanity? If the best that my medical training as a really smart person, we're all in this situation, is that I'm fearful to even go to the place of strengths because my patients expect me to deficit map. The best I can say about Mrs. Smith is that I know she doesn't have X and Y disease. Like how how when we treat people that way over and over for years and years in a career, are we not chewing away at our own humanity? That's probably for the philosophy department across the way at the University of Wisconsin, but I think it's important. And I think to really do work in the realms of health equity, undoing white supremacy, undoing racism, we have to become strength-based. I think there is no kind of other way to do it. All right, you ready? Look at my great, amazing, I know, don't do it on too much. My amazing skills. I couldn't figure out how to type the thing across there. So community wants to work on addressing high rates of teen pregnancy. Who are the experts from an assets approach versus a deficits approach? Who would you put on the teen pregnancy coalition for Dade County? Yeah, for Dade County. Shout it out, including you all on Zoom. I'm really asking you to wear these lenses, y'all.
Teenagers who either are pregnant or were pregnant or that are now grown up and they move pregnant.
Let's throw in the dads too.
That too.
Yeah, absolutely. You could sort of see in a real life example, like the token youth who's the valedictorian gets put on the coalition. But I would say that that's asset mapping really says that the people who are experiencing whatever it is, the illness, in this case, teen pregnancy, are actually more expert than the school health nurse, than all the people that you might think that would sort of be given the chance to speak on teen pregnancy. What's going on? What really is driving teens being pregnant? Is teen pregnancy a deficit at all? My wife from an Avo community would say we were almost eradicated. This is real life. The state of Arizona came in because there were high rates of teen pregnancy in her Navajo community, and they failed to ask the community, did the community see teen pregnancy as a problem? My wife was getting really good grades. She was a nerd in school by her own account, and she was being asked at 12 years old by her Navajo-speaking grandmother, why aren't you having kids yet? They almost wiped us out. The only way that we stay here is procreating. Why aren't you having kids yet? And it's a serious question. So does the community even think, or does the community of teens, in this case, even smaller, think that teen pregnancy is an issue? That's fair to ask before we start prescribing a treatment. Does their person think that their out of control diabetes is a primary issue? Well, if we knew that their lights just got shut off and they're now unsheltered, it puts a different context into this huge plan that we had to convince them on how to control that chronic disease. What are some asset-based questions you would ask this person? We'll end with this. Come on. So for the fourth time in a month, this person comes in to the ER. What are some questions you want to ask them? I'm setting you up for like a real life. It's really hard to. I saw a patient last week who came in, shackled, brought in from the tribal detention, and even me, it takes a lot to go in and really try to understand who this person is when the guard is sitting here and the guy's shackled and he's in jail clothes to be strength-based. Luckily, I had a picture of my family sitting over here, and I started the conversation by talking a little bit about the picture, and then I think they needed a clearance to get to a behavioral health, a detox kind of program. So actually that was great because I didn't have any medical thing to focus on. So I really just wanted to hear where do you want to be in 3 months, in 6 months, in a year? He started talking about the toxicity of the living situation that he came from that kept through addiction, getting him thrown back in jail. we even got to a place where we're talking about what his lows could actually do to, if he, because he said something that made me think he might be headed to actually help others through their addiction. So higher level, and I know it's late in the day for this, but actually every deficit is really a strength in disguise. So think of like what a person like that could do through, you know, the support, getting well themselves and leading others to sobriety, because they can look them eye to eye and say, I've been exactly where you are. I've been at that place where I didn't want life to continue. I've been at that place where another drink, another injection was all that seemed real for me. As one of my heroes back in Albuquerque says, a BTDT, been there, done that. So I'd ask those kind of questions. And so I have a patient in real life. Sorry, I'm not going to get to tell you about running medicine, but I'll just throw this slide up real quick. Clinical app. I take a life story for about 15 minutes with every new primary care patient in a university system that's overstrapped and underfunded and all of it. I still do it. I don't care. I'm worth nothing to this person if I don't start by understanding who they are. I also have a handwritten letter that sort of is my, not life story, but it's a hello and welcome that people really seem to appreciate. It allows me to me, it's a big power differential. Here I am asking you to tell me things that you probably don't tell some of the people closest to you in life. And so the only way that that exists is the power differential of a doctor almost sort of violently probing into your life. So to even that a little, I'm not going to say to equalize it. I have sort of my life story, and I have always like family pictures in my rooms and try to personalize it, listening more than talking, really honoring that each person's the expert and we're just there to be along for the ride. So this is the person. Real life, I take care of him for four different times during my intern year in a given month. Again, just look at what this sentence, show this sentence to a non-medical friend and ask them what it says about the people writing the value system behind the sentence. So let's give a person a name. Probably a good place to start in being strength-based is naming people and humanizing them in doing so. I know there's an interesting debate about whether we do harm or good by in an opening sentence listing things like race and ethnicity. So I acknowledge that, but I'm just going to say in this case, I think it's important to humanize and I'm doing it in a strength-based mindset that I think as a Dene Navajo artist that's important. And just that last line here that we have struggled to meet, not, oh no, he's back again, but clearly we're failing. We are failing. He's not failing. We're failing because he's back again. So the night before he leaves, the last time he draws, he asks the nurse for a big pen and a piece of scrap paper, and he draws this and he hands it to me as he's leaving the hospital. Raphael would become a leader in our nonprofit organization. He said something quite, he said a couple really profound things. I mean, number one, not a single person in these 4 hospitalizations talked to me like I was a human being. But we all came to work saying service was our goal. Number 2, y'all gave me some great lectures on what I'm doing to my liver. Told me every AA group, every time, just broken record. No one asked me what I thought was the key out of addiction. I would have told you, I'm real simple. When I do art, I'm sober. Strength-based question. What do you think are some of the keys for overcoming your addiction? Dr. Kaufman actually taught me this, one of our esteemed folks at UNM. Don't focus on what do you drink, who do you drink with, how much you drink, but bring me back to the last time, even if it was 6 hours of sobriety, what led to that 6 hours? I really want to know what was going on. What made you even decide to try to stop drinking? But Raphael clearly needed to do art. He ends up going to our local healthcare for the homeless and leading classes, teaching people how to use art to help them get through and out of addiction. So just like I did with Grandpa Bahi many beads, I'll sort of ask you, is this Raphael? Or is this? And with that, hopefully I've raised some good hard questions, given you very few answers, but maybe a couple thoughts of like tangibly how you wanted to workshop some things and be the social scientists that we are as healers, and chart a sort of different course for where you want to go with your patients tomorrow, the next day, the next time you see that person that came to mind. So thank you so much for having me. Thanks for being really attentive. I didn't even have to ask for, I know as a resident, it was really hard to just actually pay attention when I knew I had 6 charts that I had to write. So thank you for the best gift, which is just being present with each other. I'll leave it there.